Thank you so much for the opportunity to be here. I really appreciate Hussein for organizing a terrific meeting and all the organizing steering committee members, the Ministry of Health, the KUA and the AUA for supporting my travel here. So Dr. Farhad's last talk and the question that was directed at him towards him about reducing radiation exposure and X-ray free PCNL couldn't have been a better setup for the talk I'm about to give you. So a lot of my research is actually about using ultrasound in different ways, and in the last 4 or 5 years we've actually been applying ultrasound to PCNL and other surgical techniques to show that, number one, it is an achievable goal. So if you want to eliminate radiation from your operating room with PCNL, it is achievable. And I'm going to walk you through kind of that argument for why that is, and then also a little bit on how do you get there. So both the access and the dilation, and then some of the research that we've done in terms of impact. The problem, I think, or not the problem, but the starting point is that we live in a fluoro world. So when it comes to PCNL all over the world, we just do fluoro to get access. That's the way I train, that's the way most people train around the world. And so when you think about ultrasound, just like Dr. Farhad was saying, people think that nobody does it, really. And if you look in the literature from, in the last 20 years, there's a couple of papers here and there that were written early on. And folks who are using ultrasound for access and for the rest of surgery, maybe Asia, South India, some parts of Europe and the Middle East, but not a lot. But when you actually think about the whole world, the most number of people who are putting tubes into the kidney are really interventional radiologists. And just like what was mentioned in the last talk, they use ultrasound. And so the reality is that the vast majority of tubes that are put into the kidney are done under ultrasound guidance. Now, I would argue that interventional radiologists are not better surgeons than urologists. So anybody in this room could do what they do, and we can do it better. I'll tell you where I started. So like I said, I trained in fluoroscopy at UCSF. I'm at the University of California in San Francisco, trained in fluoro my whole life. I was at one of the World Congresses of Endourology a number of years ago, and somebody said, well, you're Chinese, that guy's Chinese, why don't you guys get together and talk, because you talk the same language. So a random happenstance meeting of some folks from China, and this fellow right here in the middle is Jiangxin Li, and he has done 20,000 plus PCNLs over the course of his career. And a lot of people in China say, oh, I've done 5,000, I've done 10,000. He's really done that. I mean, he's an amazing human being, a great teacher. And so after we got to talking, we realized, well, we kind of do things differently. It would be great to go visit you and you come visit me. So I went to go see him in his operating room. He was very kind to show me this video. And you can see here that he did things totally different than I have. This is like a 1970s, 80s, old ultrasound machine, unedited video. In about 6 seconds, he has stuck a needle into the perfect position in a kidney, and you see urine coming out. And so I looked at that and I said, well, I've now met a person who's done 20,000 PCNLs. He can do this. It is unachievable by any other human being in the whole world. So that was a lovely visit, but I didn't really get very much out of it. But it was really it stuck with me. And when I came back to the States, I just tried it. So just by looking at him and copying his moves and looking at his video, I've got a much nicer ultrasound machine, obviously, and this is the needle coming in from the upper pole of the kidney. And I'm just copying what he did. And again, unedited video, about 12 seconds, and I put a needle into the kidney. That was the moment that I said to myself, okay, I think that there's something here. If all of interventional radiology does this under ultrasound, and I could do this after 6 cases of just figuring out on my own, I think we could all do this, and we could change the way that we do PCNL. So I'll walk you through the skill sets that we've now developed in the last 4 or 5 years. And I can tell you that now our residents who traditionally would learn fluoroscopy, not very many of them actually did their own access when they left practice. And nowadays, most of them are leaving their practice and they can do a nephrostomy tube, they can do their own PCNL access. And this is how we break down the skill set. The first skill is about imaging, and I think imaging is really important. I'm standing here as the primary surgeon. My assistant is injecting a little bit of saline into the kidney and holding my ultrasound probe. This is kind of a faded picture, but if you can get a picture of the parenchyma, the renal fat, this dark is the collecting system and the stone. If you can achieve that picture consistently, you can do this. We talked about this at the workshop yesterday, but I'll walk you through my kind of step-by-step here. So this is our typical American. We used to think we were the most obese country in the nation, but I'm finding that we're starting to lose to other places. But this is the 12th rib, 11th rib, 10th rib, and there's the hips in a prone position, are typical landmarks. When you start with your probe, a curvilinear 3.5 to 5 megahertz probe. So everybody has this abdominal probe in your operating room as long as you have an ultrasound machine. It's a standard probe. I tell my residents, just lay it against the body parallel to the paraspinous muscle and just find the kidney. It is usually higher than you think. So most people, because it's a soft spot right here in Pettit's triangle, you start looking over there, you got to go a little higher than you think. Once you find the kidney, then the goal is to turn your probe so it's parallel to the ribs, and in that axis you get a nice long view of the kidney, and then you can actually figure out where you want to stick your needle. This video kind of walks us through it. I use saline against the body. These are my landmarks. This is a supine position. Hips, 11th rib, 10th rib. Saline instead of gel because it leaves your fingers a little more clean. This is that abdominal curvilinear probe. So again, it's a 3.5 to 5 megahertz probe in order to do this. And I just lay it against the body, parallel first, and then once I find the kidney, I'm going to first orient my probe. So I'm pressing the foot side of the probe, which should move the right side of the body. Since it moved the left side of the body, I flip my probe 180 to orient the same. And then I rotate my probe so it's parallel to the ribs now, and here's my kidney. Parenchyma, renal fat's the white, the dark is the collecting system. And if I can get this picture in consistently, then I know that I can stick a needle into the collecting system every time. The other nice thing about ultrasound is that there are some things you can see that you know not to stick a needle into. This is called the pleural sliding sign. So if you see a bright white thing coming in from the head side of the patient every time they breathe, that's the pleura. So you don't want to stick a needle into that. If you see sparkly stuff on the right side of the screen that's moving around, that's bowel. So don't stick a needle into that. If you see anything that looks like a liver or a spleen and it's sitting above the kidney, don't stick a needle into that. Whereas if you compare it to fluoro, this is the liver, and this is the bowel, and this is the, I don't have any idea where those things are in this picture. So there are some advantages to ultrasound. It's not foolproof, but at least you can see those perirenal structures. So there's an advantage to ultrasound there. But that is the first skill. If you can consistently get that image, kidney, and then you can see the calyces, you can do this. The second skill then is about learning how to put your needle into the image. So now I'm holding my probe with my left hand. I'm a right-handed surgeon, so I use my non-dominant hand to hold my probe. And I stick my needle in either in front of the probe or from behind the probe. In front of the probe for upper pole and mid-kidney punctures, and behind the probe for lower pole punctures in general. And again, this is my picture. Here's the kidney, parenchyma, renal fat. The dark spot is the collecting system. And now a needle, because it's metal, looks very bright under ultrasound. So if I can bring this needle into the collecting system under vision, I can get my access. And we've described a couple of ways to do this in the literature now with hand positioning. You can put it in front or behind the probe like I mentioned. You can come in from the side of the probe too. This I call the transverse hand position. It's a little bit harder to do because you have to be better at ultrasound imaging, so I don't teach this. What I teach to trainees and people who are starting out is the longitudinal view. So again, this is my probe here. It's lined up to the long view of the axis, so this is a sagittal view of the kidney that you get. And on that picture, that's that long view of the kidney, parenchyma. This is the collecting system, that's that dark stuff. The needle is coming in either in front of or behind the probe, and the needle, you should be ideally looking for the whole long view of the needle as it comes in. If you can consistently bring that needle into your image, that's the second skill in order to actually accomplish ultrasound-guided access. And the advantage of doing the longitudinal view is that you can see the whole needle the whole way, so you can make sure that you're not hitting things like bowel and lung and liver. The disadvantage is that you have to coordinate your two hands, which can be a little bit tricky when you're starting out. Thank you. I'll show you a video. So yesterday in the workshop that Hussein and his team arranged, which was terrific, we brought a model here. It's the same model we use to train our residents. In this model, the targets are nice and bright and white. There's two techniques to get your hands oriented. One technique is to keep your needle hand very still, and I'm fanning my probe back and forth to find where my target is. And once I find where my target is, then I leave my probe very still, and now I'll move my hand over to bring my needle into that target imaging plane. So that's the first technique. Move your probe first and then move your needle. The second technique is to leave your hand with the probe very still so I'm on my target, and now I'm going in and out of plane with my imaging with the needle. So I'm bouncing it in and out of plane. Once I find the imaging plane where my target is, then I'm going to advance my needle forward so you can see the needle coming right into that big white target. So those two techniques, if you can figure out how to get your needle into that imaging plane and advance it into your target, the collecting system, and we're using a simulator, so John Denson will be very happy here. So if you can figure out how to actually do that, then you can accomplish access. Now, over the time that we've done this now for the last few years, I think that there are some distinct advantages of ultrasound versus fluoroscopy. I think that you can be accurate with your needle placement with either technique. It's just a matter of practice and then figuring out how to get good at one thing. Now, when you actually think about the selection of the posterior calyx, we spend so much time thinking about in fluoroscopy how to get into the correct calyx. Under ultrasound, it's a lot easier because what you see is what you get. If you can find that picture of the kidney, anything that's close to the top has to be the posterior calyx in a prone position. And so getting into the right calyx can be a lot easier under ultrasound as long as you can understand your imaging. The other advantages I find are that visualizing the structures around the kidney I think is an obvious advantage of ultrasound. We've shown some data that I'll present to you later that there's some cost reduction. And obviously this radiation exposure reduction is big, and a lot of the research that we do is actually about radiation exposure for patients with stones. And so that's a huge advantage. The biggest thing, though, that has kept me kind of working on this over the last years is that the learning curve is much shorter. And I think that when, so I've got a good friend of mine who, when he initially saw this talk, said, okay, well, I'll give it a try, Tom. I'm not super excited about this, but I'll give it a try. And he's a person who actually had interventional radiology getting his access all the time. And now, a year later, he's doing this consistently and fluoro-free for all of his cases for PCNL. And I saw him the other week at a meeting, and he said, you know, what's cool about this is that it feels fun. So if you can kind of wrap your head around that. And I think it's because the learning curve is more achievable. When we look at fluoroscopy to get access, people have published that it takes between 60 and 120 cases to actually achieve mastery of fluoroscopy-guided access for PCNL. Whereas, this is me coming back from China, didn't really have a teacher, kind of saw one guy do it amazingly and then came back and tried to feel it out. Just in that context, it took about 20 cases to get through a learning curve where I was not very good at this. By success of ultrasound access, I mean I got a needle in, I could use it to clear out stones, and then we accomplished the surgery. It took about 20 cases to get to a reasonable inflection point. As I mentioned before now with my residents, now that we actually have a firm teaching system in place, it takes them about 6 cases. So if they can do it consistently for about 6 cases, a moderate hydronephrotic kidney with a smaller stone like a straightforward PCNL, they can do this. And so at this point, when I go to the public hospital for me, and I'm teaching the residents, by the time they get to their chief year, I can kind of stand in the background and just watch them do it, which is kind of a fun thing to see. So hopefully I've convinced you, it's not going to be easy for you to learn the whole process in one lecture, but hopefully I've convinced you that it is achievable. If I can do it, and interventional radiology can do it, anybody in this room can do it. And those are the 2 skills that you need. Now, what about the rest of the procedures? So the talk is really about X-ray-free PCNL. So it seems like an impossible thing to achieve because that's what we've been told for years. But I can tell you that 95% of the time now, I don't even wear lead in my operating room. So I can do this case tip to tail with no fluoro whatsoever. And this is what I saw when I went to China. So again, this is Dr. Li, who's an amazing surgeon. He's now gotten his access in. They should use this shorter wire that is made by a Japanese company that we can't get in the US. And he's using serial dilation. So this is like a 10 French dilator. He puts it down, and then he gets to his next dilator. So he's doing serial dilation, again advances it, and gets to the perfect place, stops, and then backs to the dilator, then puts his next dilator in. And you're probably wondering to yourself, well, where's the X-ray machine? Where's the ultrasound machine? Where's any of that? So he's doing this entirely by feel. So he's feeling for the vibration of the wire on the back end as he holds it. I looked at that and I said, that's impossible. We cannot teach that anywhere outside of China where you have 20,000 patients that you can do. Because he is a master at this. He could be a blind samurai and he'll cut you right in half, no problem. For me, I'd be a blind squirrel walking off a cliff. So I looked at that and I said, okay, we need to do this better. So a lot of the system we've developed in the last couple of years is figuring out how to adapt the instruments that we have to achieving the same goals that he's gotten to. So I've shown you the access portion. When it comes to dilation, this is a wire. A wire under ultrasound is very bright. As long as you use a PTFE wrapped wire, it's very bright because it's made of metal. So hydrophilic wires like the glide wire, the high wire, all those things are impossible to see because the ultrasound goes through them. But if you can use a wrapped wire, and everybody has one in your operating room, it's very visible. Now here's where it gets a little bit tricky. The dilators that we use, so again, this is my wire. I'm standing here. I'm using a plastic, essentially, serial dilator set, so like an Amplatz dilator or a fascial dilator. Those are invisible because the ultrasound waves pass right through them without bouncing off. And so instead of looking for the dilator, I'm watching for the bright wire signal to disappear. So the dilator tip is right at that junction where the wire is no longer visible, and that's how I know where the dilator tip is. When you put the balloons in, so I do recommend, you can do this with serial dilators with an Amplatz set, but a balloon is easier because the balloon, every balloon, this is a Bard X-Force balloon, but the Nephromax, the Cook balloon, they all have a little metal marking at the tip. And that metal marking comes off as a bright little spot right here. So you can see the tip of the balloon if you're very good at imaging to be able to accomplish this. And then once you blow the balloon up, you can actually see the balloon itself because it's filled with fluid on the inside, which comes up as dark. So I'll show you a video now to put all those things together. So here I am, I've gotten my access, I'm putting my wire down, and you can see as the wire goes in, I'm using this one-handed move now to pull my needle back. The wire is very bright. Here's the collecting system here, that's the wire as I'm pointing out, and you can see it wrapping up there, and if you jiggle the wire, you can actually see it moving around. Now I'm going to advance this plastic dilator, and you're going to watch this wire disappear. So there's the tip there, and here my wires disappeared all the way down to here. Now I'm going to back my dilator up, and you can see here as my wire reappears, that's where I can figure out where the tip of my dilator is. And then my balloon comes in, so my assistant's holding the balloon in the back. I'm advancing the balloon now. Here's the tip of the wire. And as the balloon comes down, you're going to see it come through the fascia, and then it's down here at the bottom. It doesn't project very well, but there's a little bright spot at the tip of the balloon that you can see. And then my assistant is putting the balloon up now, and you're going to see the sheath, the contours of the balloon blowing up, and that's going to be that dark spot that you can see after it's inflated. So all of this can be done under ultrasound guidance. I would say that the first part of the talk, when I talked about access, you can achieve that if you've got a reasonable teacher and a system to learn how to do it in less than 10 cases for a straightforward patient, you can achieve that portion. For the dilation, you need to be a bit better at ultrasound, and so I'd probably say that, you know, we have 3 residents a year. All 3 of them, by the time they get to their chief year, can do access on their own, but I would probably say only half of them can do the dilation on their own by the time they graduate. So it takes a bit more of a learning curve for you to get there, because you have to be much better at the imaging, and we're using a lot of instruments that are adapted from fluoroscopy. So I think with time, companies are going to start making things that are better for ultrasound, because I do think that this is the future.
Dr. Thomas, 1 minute to go.
Thank you. I'll show you some tips and tricks. And the major thing is when you get your imaging here, you really want to be able to adjust your depth so that you've got your kidney pictured here in the middle. And I'm just adjusting my depth so the kidney picture is right in the middle and it's nice and big. And I'm going to fast forward this for just a second. And then the other way to kind of get your image well projected is these gain levers there. I push them up to make the kidney bright enough for me to see and not so dark that it's hard to see them with my eyes. Those are the only 2 things that I adjust when I'm actually getting my ultrasound on there. A video here in case you want to get a second look at it. And I'd say that if you're going to transition to ultrasound, just be consistent, 5 minutes with each case, and then prepare with the intent for fluoro in case you need a backup, and start with easy cases. So we've looked at BMI. If you take the regular learning curve and you look at people with a BMI above 40, it's a lot harder to do. So start with moderate hydronephrosis, skinny patients, and small stones, and you'll be able to achieve this over time. The very last thing I'll just say is that over time now in the last 5 years, we've seen a lot more people picking this up and making that part of their practice, both in the United States and outside. I think it's something that's adoptable by most urologists and adaptable to any training environment. This has been a nice effort over the last 5 years with a lot of collaborators around the world, and we've been lucky to have gotten NIH funding. I really appreciate your time and interest. Thank you.